Good morning. Today we will be having a class on the anatomical landmarks in the maxilla. The glossary of prosthetic terms defines an anatomical landmark as a recognizable anatomic structure used as a reference point. The significance of anatomical landmark is that the anatomy of the edentulous ridge in the maxilla and the mandible is very important in some of the aspects in the designing of a complete denture. The consistency of the mucosa and the architecture of the underlying bone is different in various parts of the edentulous ridge, both in the maxilla as well as in the mandible. So, some parts of the ridge are capable of withstanding high forces when compared to other areas which in comparison can only withstand very little force. And a thorough knowledge of the anatomical landmarks is essential before even we try to take an impression, because we need to know where the forces can be applied within the physiological limit or at that particular area, so that there is no damage to the tissue that is underlying the particular region in the impression. So it is very important, even before we know how to make an impression, to know about the anatomic structures that we are trying to make an impression of. Now, coming to the first structure, that is in the oral cavity, that is the mucous membrane. The entire oral cavity is lined by a oral mucosa, and the oral mucosa has two layers, that is the mucosa and the submucosa. The mucosa has keratinized stratified squamous epithelium, as we all have studied in the previous years about in the histology part. The mucosa covering the hard palate and the crest of the alveolar ridge, including the residual attached gingiva, is called the masticatory mucosa. Now we can see that the gingiva, after losing the tooth, what remains of the gingiva and the soft tissue in the hard palate and the crest of the ridge is where the patient even if they cannot masticate in the truest sense, where that is the place where they try to masticate. So it may be helpful to know that there is that areas the mucosa will be keratinized and more resilient to forces. And the submucosa, the thickness of it varies, and the consistency is also varying in different parts of the denture base area. That is the entire area that comes under the denture, and when this area is thin, there is a chance that the particular area get traumatized easily, as there is little, the submucosa gives a cushioning effect to some areas, and if that thickness is very little, there is a chance that it may get traumatized during a mastication or some other process when there is a complete denture placed over it. And when the attachment of the submucosa is very loose, or if it is inflamed or edematous, there is a chance that the processes which was taken and for which the impression was taken when the mucosa was very healthy may come off very easily, as there is no support for the denture in the particular area. Okay. And the denture, whereas the keratinization is reduced and the stratum corneum of the epithelium is thinner, and this reduces the resistance of the epithelium to trauma. As we know, when the denture wearer doesn't have its own natural tooth, all the forces that he encounters while mastication gets directly transferred to the mucosa when we use a complete denture. Now, there are options where we can dissipate the forces either by using a tooth supported overdenture or an implant supported overdenture, but when the patient uses a traditional complete denture, the forces tends to get dissipated over the mucosa, and this makes the mucosa of the complete denture wearer kind of thin, as a reaction to the force that is continuously applied onto the mucous membrane. Now, coming to the bony structures of the maxillary arch, the maxillary denture is supported by the right and left maxillae anteriorly, and the posteriorly the palatine bone is present. That is a process of the zygomatic. The maxillary denture is supported by the left and right maxillae and posteriorly by the palatine bone. And the hard palate is comprised of palatine process of the two maxillae and the palatine bone. and the two maxillae are joined together at along the sagittal plane at the medial palatal suture. Now in this figure, there is a sagittal cross section of a human skull. In here we can see the frontal bone, the nasal bones, the sphenoid bones, the lacrimal bone, and the maxilla. Now here in the anterior part of the maxilla we can see a separate bone, and in the posterior part there is palatine bone. Okay. The anterior most part of the entire hard palate is comprised of the maxilla, and posterior part is formed by the palatine bone. Now this is an image of a completely edentulous patient, and here we can see the soft tissue covering the hard palate, and the irregular areas that you see in the anterior part is the rugae, and posteriorly we can see the soft posteriorly we can see the junction between the hard and the soft palate. Now coming to the any anatomical landmark in the maxillae or either in the mandible can be divided into three kind of structures, that is the limiting structures, the supporting structures, and the relieving structures. The limiting structures are those structures that confines the end of the denture, that is the structure where you stop your denture's extensions, okay, and your denture should not go beyond that kind of particular structures. Okay, then comes the supporting structures where you are supposed to design your denture such that the force that is applied through the denture gets dissipated more or less to these areas. Okay, those are the load bearing areas of your maxillae or your mandible. Okay, and we use this region because it has been proved through various studies that minimal ridge resorption takes place when we apply a continuous force onto that structures. That is, it can withstand a much higher force than other structures in the maxilla or the mandible. Okay, then comes your relieving structures, and these contains fragile structures and more easily resorbable bone or soft tissue. Okay, in these areas there is high chance when you're a complete denture wearer, there is a high chance that you may traumatize your mucosa, or there is a high chance of initiating a resorption. That is because the mucosa cannot support the forces entirely, and these structures are to be relieved. These structures may contain vessels or any other vital structures that are passing through it, and there is a possibility that we may injure the underlying structures when forces are applied to this. So we are supposed to relieve the areas and such a way that when denture wearer uses the complete denture, minimal amount of forces are applied to these structures. Okay. Now, the limiting structures in the maxillae are the labial vestibule, the right and left buccal vestibules, the hamular nose, and the anterior and the posterior vibrating lines. Now, the labial vestibule, it extends from one buccal frenum to the other. Okay. In the image, we can see the anterior most. There are 4 orange colored dots in the sulcus. Okay, the anterior most ones is supposed to represent your labial frenum, and the ones to the side are your buccal frenums. Okay, in this image, the labial vestibule extends from the left orange patch to the orange patch in the right side. Okay, and its other surface is formed by the fibers of the orbicularis oris. That is the floor, and the other structure is formed by the muscle orbicularis oris, and it is bounded alveolar interiorly by the alveolar ridge. That you know, because it is a structure that comes in between between your your lip, your cheek, and your alveolus. So alveolus comes inferiorly, and it is formed by the orbicularis oris muscle. Okay, then comes your buccal vestibule. Okay, it extends from your buccal frenum to the hamular nose, and the size of the vestibule varies with the contraction of the buccinator muscle and also the movement of the mandible. All the soft tissue is movable in variable degrees, and when we come to the buccal vestibule, the size of the buccal vestibule is determined by the movement of the mandible as well as your buccinator muscle, that is your muscles of mastication. Okay, then comes your hamular notch. It is also called the pterygomaxillary notch, and it is the palpable notch formed by the junction of the maxilla and the pterygoid hamulus of the sphenoid bone. Now comes to the posterior palatal seal. The posterior palatal seal is very important in a complete denture scenario, as this is the portion where your the posterior extent of your denture comes to an end, and as you all know, the complete denture is supposed to be staying in your oral cavity with the help of atmospheric pressure. So that there needs to be a low pressure area under the denture. So you need a a seal, a tight seal around your denture. So the posterior palatal seal area is very important and critical in the success of a complete denture. It is also known as a post-dam area, and it is defined as the soft tissues or along the junction of the hard and soft palate on which pressure within the physiological limits of the tissue can be applied by a denture to aid the retention of the denture. That is nothing. The definition suggests that it is the junction between the soft and the hard tissue. Soft and the hard palates, and this is the place where you can apply apply a force that is within the physiological limits of the tissue which is underlying that area, and it aids in retention of the complete denture. The PPS is bound anteriorly by the anterior vibrating line and posteriorly by the posterior vibrating line, and laterally it is bound by the hamular notches that we saw earlier, and the PPS generally contains the fovea palatinae. These are nothing but minute openings of salivary glands. Okay, the functions of the palatal seal area is it aids in the retention by maintaining constant contact with the soft palate during functional movements like speech, mastication and deglutition. It reduces the tendency for gag reflex, as it prevents the formation of gap between denture base and the soft palate during functional movements, and it prevents accumulation of food between the posterior border of the denture and the soft palate, and it also compensates for the polymerization shrinkage. The posterior palatal area can be divided into two regions based upon the anatomical landmarks, named the pterygomaxillary seal and the postpalatal seal. The pterygomaxillary seal is that part of the posterior palatal seal area that extends across the hamular nose, and it extends 3 to 4 mm anterolaterally to the end of the mucogingival junction on the posterior part of the maxillary ridge. And the postpalatal seal is that part of the posterior palatal seal that extends between the two maxillary tuberosities. Now, coming to the impression scenario in a complete denture, the posterior border of the denture should not be placed in the mid-palatine raphe or the posterior nasal spine. That is, it should not be short of the posterior palatal seal, it should be in the posterior palatal seal area. And if there is any palatine tori or any other bony protrusions into the denture base area, if that is supposed to interfere with the palatal seal, the tori or that particular defect in the bone should be excised off and healed completely before you attempt a complete denture therapy for the patient. And the position of the fovea palatina that we earlier discussed, which is an opening of the minor salivary glands, should have be present in the should be consideration in when you consider the posterior border of your denture, and the denture should be extending 1 to 2 mm beyond the fovea palatinae. And if the mid-palatine fissure is present, the posterior palatal area should extend into and obtain a good peripheral seal. That is, if it is a fissured area, if it is not a smooth area and there is a fissure there, your denture is supposed to go into the fissure and attain a seal in such a way that it contacts your soft tissue every way. And in patients with thick ropey saliva, the fovea palatinae should not be covered, because the thick ropey saliva can affect your your retention. So as you have seen in the role of saliva when it is very thick in consistency, it does not give a it does not provide for a better retention, as there is less capillarity and there is less capillarity and the viscosity is very high, so it does not retain in help in retention, so it should not be left covered. Okay, now coming to the anterior vibrating line, it is also called the R line. It is an imaginary line across the posterior part of the palate, making a division between the movable and the immovable tissues of the soft palate, and it can be identified when the movable tissues are functioning. Okay, that is it is an imaginary line that crosses between the hamular notches of the patient, and this can be visible when the patient's the soft tissue part is moving. Okay, that can be identified when the patient makes a sound in which the soft tissues are moving. Okay, now coming to the posterior vibrating line, it is an imaginary line located at the junction of the soft palate that shows limited movement, and the soft palate that shows marked movement. This is what you say, it is a junction between the between an area in the soft palate which shows a marked movement as well as a limited movement. This cannot be identified as such in visually, because it is supposed to be the junction between where the soft palate suddenly the soft palate is attached to the as you all know, the soft palate is attached to the posterior nasal spine. Immediately after the attachment of the soft palate, the movement is comparatively less when compared to a further area, and this line comes in between. That is, it comes in between a slightly movable soft palate and a markedly moving soft palate during function. Okay, now coming to the supporting structures. The primary and secondary stress bearing areas are there in every arch, that is in the maxilla and the mandible. The primary stress bearing areas should have the primary structures are the firm tuberosities in the maxilla, the hard palate on either side of the palatal raphe, and the secondary stress bearing area are alveolar ridge and the rugae area. The primary stress bearing area in maxilla, as we said, are the tuberosities, that is the maxillary tuberosities, then the hard palate on either side of the palatal raphe, and the primary stress bearing area generally has a thicker mucosa, and underlying bone is less subject to resorption. And the secondary stress bearing area, the main secondary stress bearing area is the residual alveolar ridge in the maxilla, and the residual alveolar ridge is generally a secondary stress bearing area, as it is made up of cancellous bone and is subject to resorptive remodeling after denture extraction and with long-term denture wear. That is, we cannot consider it as a primary stress bearing area, as the bone density is very less, and it is as you all know, after an extraction the bone heals, right? So and the bone remodels, and the crest, the alveolus of the maxillae, there is a chance of remodeling that can take place after extractions, or in case of long time denture wear, as the bone has less density when compared to the cortical to the other part of the maxilla and the mandible, there is more chance of resorption that can take place. Now coming to the rugae area, that is another secondary stress bearing area in the maxilla. These are mucosal folds located in the anterior region of the palatal mucosa, and it helps in pronunciation of sounds that starts with t, n, d, l, something like that. It comes in phonetics, and that is important when you consider the manufacturing, the process, the production of a processes, when your processes are supposed to help the patient phonate. That is, it should enable the patient to speak properly. Okay, and the metal denture bases reproduce the contour, making it very comfortable to the patient. That is, we are supposed to reproduce the contours of the rugae area in the denture, so that it is comfortable for the patient and less stress is applied on the mucosa. Now coming to the relief area, these areas resolve under constant load or are fragile structures or have fragile structures which are contained in inside it, and the denture should be designed in such a way that the masticatory load is not concentrated over these areas. And the relief areas of the maxilla are the incisive papillae, the mid-palatine raphe, the fovea palatinae, and the cuspid eminence. Now coming to the incisive papilla, it is a midline structure situated behind the central incisors, and it is the exit point of the nasopalatine nerves and vessels, and it should be relieved. If not, if it is not relieved, the denture will compress the vessels or the nerves, and this might lead to necrosis of the area where the vessel distributes, and there can be a chance of paresthesia of the anterior palate as the nasopalatine vessels as the nasopalatine nerves supplies those areas. So it should not be compressed. Now coming to the mid-palatine raphe, that is the another relief area in the maxilla, and this is a suture between, as we saw the maxilla in the anterior part, we said it is made of two halves, okay, two maxillary bone that are fused across the sagittal plate. So this is the area where that suture goes, and it should be relieved during denture fabrication, as this area is the most sensitive part of the palate to pressure. As we know, it is a combination of two bonds there. That is a so that is a place where two bonds join. So it is better we don't apply much force to the palatine raphe, as it might be susceptible to injury. Okay, then comes your fovea palatinae. The fovea palatinae is formed by the coalescence of ducts of several mucous glands. We have discussed fovea palatinae a little while behind when we consider the posterior palatal seal, and the position of the fovea palatinae also influences the position of the posterior border of denture, as we saw. If the patient has a mucous saliva, we are not supposed to cover your fovea palatinae. Otherwise, we are supposed to cover your fovea palatinae. And the secretion of the fovea palatinae, when it is serous or mixed in kind, forms a thin film, thereby aiding your retention of your upper denture. Okay, that, and we discussed earlier, the ropey saliva has an opposite effect. So if there is mucus, or if there is mucus, thick ropey saliva, supposed to cover it. Otherwise, we are supposed to cover, and we have to extend the posterior border of your denture 1 to 2 mm beyond your fovea palatinae. Now this image shows your presence of the white spots on the green part is your fovea palatinae. Now coming to your cuspid eminence, it is a bony elevation on the residual alveolar ridge formed after extraction of the canine, and this is located between the canine and the first premolar ridge. Okay, this is nothing but where you extracted your canine tooth. As you know, the canine is called the cornerstone. Okay, so that you can see, when you can also feel it in your mouth, your canines, the cuspid area is slightly pronounced. Okay, that is where your the cuspid eminence is nothing where but the place where you extracted your canine from. Now coming to the palatal torre, the torus palatinus is a bony protrusion on the palate, and the palatal torre are usually present in the midline of the hard palate. Okay, this is bony outgrowths. Okay, and the most palatal torre are less than 2 centimeters in diameter, but their size can change throughout the life. Okay, it may not stay as normal. It might grow, it might shrink also. Okay, the torre should be relieved in final denture based design, and the torre, if it impinges on the posterior palatal seal areas, as we have told earlier, it should be removed, as it may compromise your your retention. Okay, thank you.